For our last conversation, we are talking about health and exactly what is working for Kenyans. Health rights. What does the Constitution guarantee you? What does it mean when you have a right to the highest attainable quality of healthcare? We'll be discussing that with Dr. Stellah Bosire. She's a daktari, she's a wakili, she's a columnist. She is an all-round amazing personality with a great sense of style, because I really want to steal this kimono. Karibu, Dr. Bosire.
Good morning, and thank you for having me.
It's so good to have you. Before we get into anything else, Jano has a lovely quote.
Yes.
That she wants to get your view
it's
on.
It's over 100 years old.
Yeah, that I dug out from.
It's 125 years old.
Yes.
It turned 125 today.
Thank you. Yes, Maria, it turned 125 today.
Yeah.
1900, July 23rd, at the Westminster Town Hall in London. There was the first Pan-African conference. It was held there. It was organized by somebody called Henry Sylvester Williams, and it brought voices from Africa, the Caribbean, the US, and Europe to confront racism, colonialism, and economic injustice, which we still face today, but that's a story for another day. Bishop Alexander Walters, who spoke, in his opening speech, he said, "We are determined to protest forever against oppression, even though it may assume the garb of law or decency." We are determined to protest forever against oppression, even though it may assume the garb of law or decency. What do you make of that?
I think, and I'm going to be very practical today, as right now we have a lot of oppression that is veiled in law. And so we are doing weaponization of the law to justify injustices. And we've been witnessing it the last 2 years. As early as 2 days ago, to one of our colleagues. And the same thing is also happening within the health sector, is that there's weaponization of the law, words like quality, dignity, which is really constitutional provisions, which are fundamental rights and freedoms. And yet when you unpack, you realize that, nope, that's not the intention. It's like a sheep in a wolf's clothing. Yes.
That's literally what I think Bishop meant 125 years ago. And Gesemayo Kamang, he was alive today. Yes. Yeah.
Injector.
Also.
That's what you are.
Yeah.
Doctor, lawyer, injector, Mbogi. So when we talk about the Mbogis, there's a new group of writers who have started, writing daily columns on the Daily Nation. Dr. Stellah Bosire appears on a day like today. Wednesday. And there's one here. Risky logic behind Duale's escapist order to hospitals. Already the headline. There's no dignity working in such poor conditions. There's no quality when one nurse is attending to 30 patients in a single shift. Daktari, what is it?
I mean, the other day, and this is characteristic of this administration. I call them roadside declaration with no justification and logical justification. Our Honorable Minister says, we are not going to reimburse facilities where patients are sharing bed, without really unpacking why in July of 2025, Kenyans are still sharing beds. His assumption is that's just a fraudulent way. In fact, he veils it, let me use the words of the minister, he veils it around, we want dignified patient experiences, we want infectious control, which in essence is actually very true. But then when you look deeply into it, is by the time a patient is admitted, that is a critically ill patient. We do not admit walk-in patients, outpatients, we only admit patients who require specialized care. And so if you see two patients, and this happens a lot in pediatrics, happens a lot in maternity, and patients with chronic illnesses like diabetes, those ones who have complications of HIV, those who've had complications of road traffic accidents, because let's be factual. Our bed capacity in this country is still deplorable. If you can just take you back a little bit during COVID, you remember we had less than 250 ICU beds in the whole country, and yet every single county required patients to actually be admitted because of the complications. And so what he's not unpacking, or what his advisors are not telling him, is that even when we have 3 patients, all of them are still receiving care. And so the burden then lies around the clinician who's providing. So the one nurse would perhaps have done, if there was singular beds, 1 nurse to 30, now has to do 1 times 30 times 2 is 1:60. And so you see that pattern. The other thing is, and it's very problematic how he phrases it, is that saying, if my bed capacity, and this is singular bed capacity for a ratio of 1 to 1, is full, I will turn away patients. I will turn away patients at Kenyatta National Hospital, patients with a head injury, patients with multiple traumatic fractures. I will turn away children who are brought in, who are convulsing. I will turn away women who come with complications of labor because there is no bed. And what does Article 43 talk about? Is that everyone has a right to the highest standard of health, including reproductive health, and also goes ahead and quantifies the right to emergency care. So, in essence, Duale has shut the door of emergency care by his directive.
Why though?
Of course, there are a couple of things that are coming out during the rollout of the failed SHA, and I will call it the failed SHA because it really has failed. We've spoken about this. And what is coming out is that the rate at which they are reimbursing facilities is not in tandem with the utilization of the facilities. And so they're in debt as we speak right now, more than I think to the tune of about 30 billion, both public and faith-based and rural facilities, And so what this means then is that they're thinking they're being frauded. And he has a reason. He has a reason. But what the problem is that reason is not based on facts. It's assuming that when you charge this bed number 30, you charge for Stellah, you charge for Janet, then you actually are double billing. What he's not doing is separating that invoice and saying, oh, Stellah came in with severe meningitis. Janet came in with diabetes complications, what you call DKA, diabetic ketoacidosis. Her sugars were crazy. And so Stellah's treatment sheet was different from Janet's treatment sheet. That's not what he's looking at. In fact, if you look at the cost of the bed vis-a-vis the cost of the treatment, the bed is very minuscule. It's a treatment, it's interventions, it's the imaging that is actually where the cost goes in healthcare.
Has this been used in fraud before?
No. In NHIF.
Like, in those fictitious inflated claims into NHIF, because that's what we're hearing all the time, fictitious claims into NHIF. Was this one of them, that a hospital with a 10-bed capacity is claiming for 30 patients? And you're like...
Yeah.
It has. And I will say this. When those fictitious, and this was actually came out from the Auditor General, when the audit of the NHIF, and it came out, it was true, is that you find an individual has been billed on a bed without treatment. That raises an audit query. An individual has been billed on surgery with no post-surgical recovery. That raises an audit query. And so when you unpack that to that level, then you actually find you find the holes. But when you do the audit and find there is actually a treatment sheet, the patient admitted an X number on this day, stayed in the wards on this day, and this is what they were treated for. There is actually a codex for the nurses that shows what kind of care that patient received. Then that is something that then you cannot be able to query around there.
So they're just being lazy.
They are just being lazy.
Okay. Yeah.
And they've invested in a 100 billion system of IT that until now we are asking, what is that and where is that money?
Yeah.
When the services that are required, we need IT services. It's very important in terms of our data, our understanding of disease, our trends and everything. But at the expense of service delivery, no, we don't.
It's too high. Dr. Ari, I wonder, it could be a combination of both. When it comes to budget, the budgetary allocation, when it comes to health budgeting, is it misallocation of funds, underfunding, misuse of funds that's causing the bottlenecks that we have?
I think it's everything.
Yeah.
In working systems globally where we have social health insurance, and when I say working systems is governments that have committed to ensure that their populations are healthy, public health is tax funded, 100%. And so we would not be having these extra malicious overtaxations of citizens in the name of funding healthcare. We would actually have a national budget and an exchequer directly from Treasury that funds our whole public health. And so there's an underfunding issue. If you look at this administration and the previous administration, what we've seen actually from Kibaki's administration is a downhill trend in terms of healthcare funding in this country. And it's so unfortunate that people have forgotten to relate the direct association and correlation. Actually, I use both statistical measures of investing in public health and the GDP. A healthy population is a more productive population. A healthy population means that we are not spending more money in curative and rehabilitative, because we've invested in the right processes. We've invested in health promotion and health prevention. Right now, what we're witnessing, particularly around the social health insurance, is there's an underfunding of the health promotion, right? That's at the basic community level. And you've seen, I mean, you saw the launch of the community health practitioners. I mean, what has become out of them? They are underpaid. They don't have a system, of, in terms of their labor functioning, where we're saying that for this expertise, this service that they are able to offer, this is how they're supposed to be remunerated. It is ping-ponged in the whole country, and it's actually pegged on development funding. And if I am not wrong, the government has only funded less than 100,000 community health practitioners in a population of 550 million people.
Right. I don't even want to go into what the recommended ratios, doctor to patient, like I don't even want to go there, but I want to stick on this money issue, because what you're saying is people don't see that nexus between healthcare and GDP and economic growth. Sometimes I think they do see it. It's more sinister than that. Sometimes that's my biggest worry, that it's intentional. When you think of things that are systematically being defunded, we had a story here on the Daily Nation on cancer patients not being able to access what they used to be able to access under NHIF. 200,000 shillings less, for example, for one patient that we spoke of. It was actually in the Taifa Leo as well, and I read the story. And one of fedha zilizotengwa waathiriwa wa maradhi hayo hatari ni tone la maji baharini. And this gentleman spoke to us. His name is Waigwa, and he spoke to the Nation and said he used to be able to have a cover of 600,000 shillings. It's now 400,000. From as a daktari, what does that mean for someone's treatment, and not just of Waigwa, but anyone else suffering from any chronic disease?
One of my colleagues this morning has shared a letter to the president. She's a resident oncologist. She's called Dr. Felicitas Bosibori. I am going to use Dr. Felicitas' letter to break it down to you, and I'm going to use a case study of a woman with breast cancer. Now, if you come to the facility and you're initially diagnosed, there's a query around, we think, because we always, you know, it's a clinical and a correlation, we have to do other laboratories. A breast ultrasound is 3,000 shillings. For anyone less than 35 years, we recommend having breast ultrasound, but anyone above 35 years, we recommend having a mammogram. A mammogram is 5,000 shillings. Now, if we look at that breast, the ultrasound or the mammogram, and it's suggestive, we're like, maybe we need to have a better view. We send you for an MRI. A breast MRI is 10,000 shillings. It doesn't end there. There's something we call biopsy, because there are multiple types of breast cancers. One which is responsive to one form of treatment because of receptors, another one which is responding to another form of chemotherapy or radio because of the type. And so what do we send you for? A biopsy guided, an image guided biopsy. It's 15,000. It's not covered by SHA. The biopsy is not enough. I have to send it to a pathology, a clinical pathologist. And the pathologist will charge for immunohistochemistry and general pathology a total of 25,000. We have not touched treatment. We're just diagnosing, because I'm not going to go into treatment before I know what I am treating. And then we have to stage it. The staging is, say, stage 1. I know you've heard, oh, they have cancer stage 3, stage 4. A CT scan for the chest, because the breasts are within the chest cavity, is to see, has it gone beyond that? A CT scan for the chest is 15,000. For the abdomen is 15,000. For the brain is 30,000. And then there's one standard test that we test just to look at the whole body. It's called a PET scan. It's a gold standard anyway for staging any cancer. It's 70,000 shillings. And there are less than 3 in the country. Now we have 70,000. So we've done our initial diagnosis. We've staged the cancer. We are like, now we know what you're going to treat. Now we're going to treatment. Now, bi-weekly, every week, we must take your blood to do tests, because what we're giving you is poison. Chemotherapy is poison. Radiotherapy is poison, meaning there will be collateral damage to your normal cells, the red blood cells, the white blood cells, the platelets. There will be collateral damage to your tissues. So every week we have to do tests. Twice in a week it costs 10,000 shillings. And then now we start you on chemotherapy. You need 8 cycles each cycle is 40,000 shillings. That's 320,000. Sometimes, if you're above stage 2B, the doctor will say, now we'll have to do here radical treatment. So we'll do something called a radical mastectomy. So there's a surgical component of it. Cost it there. It's about 100 to 150,000 shillings. And then we have to do radiotherapy. You need 25 sessions of radiotherapy. Each is 3,600. That's already 3,600 for 25 sessions. That's 90,000. So now we've done treatment. We've said 8 sessions of chemo, 25 sessions of radio. We've debulked the tumor, and now we're saying, okay, so we had staged it. We were in stage 3. Have we achieved anything? We send you back for a CT scan. Remember the CT scan was how much? And the CT scan is restaging, yes, so we'll do 3 times, every 3 months. That's 45,000. And then right now, we have something called targeted therapy, immunotherapy. Now, aside from just chemo and radio, we have new innovations where specific, like now we have something called HER2, which is the receptor. And so we'll specifically give you drugs that are specific for that. You need about 18 sessions. Each is 140,000. 2.5 million.
That's what are those?
Yes. It's called targeted therapy, which is basically Herceptin for HER2 breast cancer. So they are different. So when you take the biopsy, we'll say, hey, you have BRCA1, you have BRCA2, you have HR2, HER2, we call it HER2. So those are receptors. Each receptor of the cancer responds to treatment differently. So the one for BRCA will not respond for the one for... So the specific one, which is a common one, the Herceptin one, is 140,000 shillings per session for 18 sessions, which is 2.5 million. Unajua tumefanya chemo, tumefanya radio, tumefanya debulking, alafu tunaenda hiyo. Alafu unaambiwa it is 400 to 520, that's what they are going to reimburse in SHA. Hiyo tulishakula kwa wapi? Diagnosis peke yake.
Is my math correct? 2,750,000.
Yes, approximately 3 million.
It's not. It's not. It's okay. It's way above.
A lot. Way above. So when we saw Mzee walk to SHA with his papers and saying, "Mutanisaidia aje," this is why he was asking Mutanisaidia aje. People are saying we are seeing more cancers in the country, and it's thanks to more diagnosis, thanks to training more of our clinicians, our doctors and our nurses to become specialists, thanks to investing in imaging that is allowing us to do this. And so if it's allowing us to do this, then that means we are able to catch a lot of these cancers in the early stages, meaning the 10-year prognosis, which the 10-year chances of someone being alive is increased in early diagnosis and treatment. But it will cost them more than 3 million. Ajakula, ajaingia matatu ama ajaingia basi, ajaingia kama ni haizi tembea, anafaa kwa ndege, Jambo Jet or whatever, akuja Nairobi. Because also, these facilities are hyper-specialized. That is one. That's breast cancer. I've not touched prostate cancer from there. And I've not touched prostate cancer where they're telling you there's a cap around who can be in SHA. They're telling you it's not everyone who can be treated, can be tested for prostate cancer. And we say this is how we're trained. Anyone above, in fact nowadays we even have early onset prostate cancer. Anyone above 40 years, go every year. Every 1 year do your PSA, the way we do our breast thing, which is prostate specific antigens. Go check. Wanakuambia, no, you can't go beyond, if you're lower than 45 years, you can't. So meaning, the people between 40 and 45, we miss the diagnosis. And yet, we can actually improve the quality of life. So what happens? Mzee one day will, and I pray he does it, will complicate, will land in KNH, MTRH, Kenyatta University Teaching and Referral Hospital, and inevitably we'll have to admit him, most probably in the ICU or HDU. And every day they will rack costs. So when this government says we are committed to achieving universal health coverage, they are not unpacking to the population and saying, what are the 3 components of UHC? Number one is quality of care. Let me not even go into the chances, and you guys have covered this. Machine has broken down, right? So quality of care is dependent on a lot. It's dependent on the commodities, which are the drugs. It's dependent on the expertise of providers. It's dependent on the infrastructure in terms of the machines. That's one. Then there's another second component. Finances. It actually states this, that UHC is supposed to prevent catastrophic financial expenditure. Latif, last 1 month, umeingiza kwa WhatsApp group ngapi za mchango ya M-Pesa ya hospital? Janet, Miriam?
Kawaida.
Kawaida. Tafadhali, it's become like the thing. Like literally Kenyans, we are taking care of each other collectively in terms of our health. Right? So, and another thing is equity. What does equity mean? It means, Stellah, and that's the essence of having a social health insurance, is the person who doesn't have is able to be covered and gets care comparable to what they would get in Aga Khan, they would get in Bagathi. Like in this story, any different?
Yeah, equity is, there's so many matters to draw from what you've just talked about, whether it's equity, whether it's financial. I wanted to come to the part where Gatumu Waigwa says, relief came when NHIF began covering the bulk of his expenses with an annual allocation of 600,000, but it was short-lived before the president told us to migrate to SHA. The transition proved catastrophic for his allocation. It's a question we've asked a lot, which is, we've had a lot of these NHIF shift SHA conversations. I'm just trying to get from you, if Dr. Stellah was asked to iron out some of these bottlenecks around the funding, around what chronic patients can get, around what NHIF was covering vis-a-vis what SHIF and SHA are right now. What's the first thing that you think needs to be streamlined or untangled to ensure that there's equitable access, especially for people like Gatumu Waigwa? In a perfect world, if you were at the helm.
If I was at the helm, in a perfect world, the first thing I'll move my money into is health prevention and promotion. Because that means early diagnosis, that means screening and mass screening. That means for every household, I'll map these community health practitioners. I'll use them to map every household that has a certain risk. You know the risk profile, about 40, 35 for women, about 40 for men, and the common cancers. I will first do the screening. The earlier we get it, the lesser it costs to us as families and to the government as the providers of the public health. That's the first thing. And the second thing would be, there are those ones who are already sick. What do? We have an emergency and chronic fund. What is that fund for? Guess what? There is no money that has been put into that fund. How then are we supposed to treat people when there is no money, when they put caps like, before you are able to access the emergency and the chronic fund, you must have contributed.
Which beats the whole point of it being emergency or chronic.
Actually, Kenyans right now, if you don't pay for SHA, you don't access services. In NHIF, and that was the essence of equity, during NHIF, and I'm not saying NHIF was the magic bullet, the silver bullet. What I'm saying is, for those of us who were in formal employment, the amount of the taxes that the amount of money that we used to be deducted would actually go and cover for those people, because we must be honest. More than half of the population of this country live are low-income earners. And so you can't tell a household that you must be able to pay this amount of money when they have to make a decision between nitalisha watoto na 300 ama nitalipa SHA. Na akienda hospitali, the first thing anaulizwa, uko na SHA? Kama una SHA unaambiwa, you pay the whole year. First the illegality around that. You know, you're paying for a service for a whole year before you're able to access it. Basically saying you're conditioning a right, a fundamental right. You're costing a fundamental right, when it's a responsibility of the state to offer the highest standard of health. You're costing it.
Hapa lakini, I want to ask, is it financing?
Latif paka sura imebadilika. Akipole.
Financing is a key component here. Whether you're financing from tax, you're financing from contributions and so on and so forth. What do we require in order to be able to afford it? To afford a proper universal healthcare. So even if we talk about primary healthcare that is completely 100% tax funded, for it to work, how much do we need to actually allocate in the budget for it to work well, so we can have screening at the most basic level, so we can avoid?
So we have a baseline, which was agreed in a convening called the Abuja convening, and the baseline is 15% of the GDP. So 15% of our GDP should be allocated to healthcare. In that way, it means essential care will be provided to the population, because our GDP is tied to our population. So we are saying in 50 million, if we took 15% of I don't know our latest GDP, I need to get that
12
number. 12 trillion. We took 15% of 12 trillion and we put it in healthcare. We are assured of at least essential care. Healthcare will be provided to the population. That's the first thing. But that essential...
Is that practical?
It is very practical. Rwanda has done it. Senegal has done it. Why can't we do it? But I'll tell you why it's impractical in our case. Why have we spent 100 billion on a system that is not functioning? Why are we having middlemen who are taking part of the reimbursements that are coming from SHA, from the public, from the government? So basically what I'm saying, Latif, is we have a lot of holes. If it's not misappropriation, if it's corruption, if it's not corruption, it's misallocation. If it's not misallocation, it's just blatant non-prioritization of healthcare in this country. And also negating the responsibility of the state to development partners, and that's why when USAID left, what happened?
A gaping hole was left.
Literally an entire hole. And people think it was just HIV. In fact, I wrote about it in our Daily Nation. Yes, it wasn't just about HIV. The USAID funding supported heavily cervical cancer screening, supported heavily maternal health, supported heavily child health, and adolescent health, and other key vulnerable and underserved population. So that was yanked
from there.
And then our Honorable Mbadi, he reads the budget, one of the biggest spots, which is around HIV. Instead of putting more money there, he removes money from that pot, and removes 11 billion from that pot. And so we're already on negative from lack of USAID. Then he goes on that pot and removes that pot. But what is really now extremely annoying is you read the Daily Nation yesterday and you see the appropriate budgets that the parliament has been passing and where the money has been going into concrete, into repairs of State House. Right? We're paying in billions airfare.
Yes. We've talked about that many times. I know we also need to come to your, how vocal you've been around the protest. We'll come to that in a bit. I want to talk about the quality of health care, the quality of health bill.
And patient.
Which you've mentioned is problematic. So maybe go into that and whether it captures any of what you've also spoken to moments ago.
One of the characteristics of this administration, it loves being the judge, the jury, and the executioner. So basically the quality of health care and patient safety bill defines or really speaks and affirms their role as the judge, the jury, and the executioner. So let's start. We already have structures on the ground around regulation of healthcare. As a medical doctor, I'm regulated by the Kenya Medical Practitioners and Dentists Council, right? And in terms of my licensing, they also license and accredit healthcare facilities. So what this bill rather is proposing, it's proposing that it will handle registration, licensing, accreditation, inspection, and enforcement. How do you set a thief to catch a thief? And I'm saying this very, very intentional.
Who will handle? KMPDC?
No.
Who?
They are removing that responsibility now, putting it on the quality of healthcare if this bill is to pass into an act of parliament.
So which entity?
To establish an authority.
An authority.
So a new authority separate from
KMPDC, separate from the nursing council, separate from the clinical council, separate from that.
To deal with just the infrastructure?
It's not the infrastructure.
It's what?
Yes, they are dealing with the registration. The licensing, the registration of facilities,
right.
The licensing of facilities,
Fine.
Accreditation, inspection, and enforcement.
So they're dealing with a facility, and then KMPDC will deal with the humans. Just like the Nursing Council deals with the humans, and the Pharmacy and Poisons Board deals with the humans called pharmacists. What's the issue?
The issue is enforcement. You cannot be the one who is licensing, and you cannot be the one who's accrediting, and then you're the one who's also coming to be punitive.
Isn't that what KMPDC does now?
What KMPDC does is that it has devolved an independent body that this bill does not recognize, which is the tribunal. And that independent body now comes in if Stellah Bosire has a negligence case to answer. That independent body comes in. If you look at some of the changes that happened around the KMPDC, it never used to be called KMPDC. It was Kenya Medical Practitioners and Dentists Board. But the council came in because of the realization of the representatives of the patients and the realization of the people with public knowledge, which is relevant to the practice of medicine in the country, and even bringing in the judiciary on board. And so there is that part that is being taken care of. And so there will be chances of conflict of interest. And that's why even for KMPDC, that body is very independent with different people. What it does, it just reports to KMPDC.
Okay.
So then the question would be, why do health practitioners and health facilities want to oversight themselves?
Yeah.
They cannot oversight themselves, right?
So this would be then the authority being proposed.
Right now, this is what you're doing.
No, maybe let me rephrase again. We have the union, we have rather the council. The council deals with the doctors and the facilities, right? And then we have the nurses. The nurses does, actually, it's only the KMPDC that licenses and regulates the facilities.
Yep.
So be it owned by a clinical officer, be it owned by a nurse, it's owned by them. Now, what this bill is proposing is that it's proposing to put everything under one. One, it's defining what is needed. Aside from defining what is needed, is saying that we are the ones who are going to give you the certificate of quality. And finally saying that we are also the one who are going to punish you. Now, the beauty about how KMPDC is structured, under one roof, but still with independence of the different sectors around the tribunal that listens to issues around malpractice, issues around facilities that are not licensed, comes in there. And that's a very important independent. And the beauty also about it is that there's a recognition that if there is the board, rather the tribunal cannot handle that matter, it moves the matter to where? The High Court. And so you can actually see a pathway around which enforceability comes in. The work of the judiciary is to be able to support that. And that's why they've been supporting through the legislation for the doctors to actually have the regulation under that body. And so if it does this, then the other thing that is also negating is the function around, if I don't get redress, where do I go? That's a question that he's asking.
Right.
And I think the other problem that it also causing, because it talks about patient safety, which is something that we need to talk about in this country, right? Yep. The other thing that it talks about around patient safety is saying, if you're found to have a tort of negligence, you will be fined 50 million or 10 years in imprisonment. What is the basis of that? Proportionality, reasonability, what is the basis of that?
What's
right?
global best practice as regards negligence for medical practitioners?
There is no baseline around how negligence is treated. It depends
also
on
as
the
a doctor, negligence versus malpractice, what's the difference?
All right. So negligence is, I have a duty to care. You come to me, I have skills. And a reasonable doctor would expect, for example, if you came in with a broken arm, for me to do an X-ray, to do bloods, and then to put a cast or to fix the bone. But I didn't do any of that. And so I caused you harm, that you got what you call compartment syndrome, and we ended up amputating that arm.
Okay.
So what was expected of me,
You didn't do.
I didn't do. And that is a tort of negligence, right? Which is a civil issue. Now, malpractice also comes in, for example, I think you guys have been highlighting it for a long period of time. I have been trained as a clinical officer. I have been trained as a nurse. I have been trained, and to the extent of my abilities, this is what I should be able to do. But then I cross over and I become a neurosurgeon, or I become an obstetrician and gynecologist. I start opening up wombs of women. That is malpractice.
Okay. Now let's go back to this fine, 50 million shillings or 10 years imprisonment. Again, negligence, is it a criminal or a civil matter globally? I'm trying to...
It's actually both, depending on
The level of harm.
On the level of harm and the complainant.
And the complainant.
Right?
Okay.
If when there is loss of life, that's when a lot of the times it becomes criminal, because then there's a loss of life, so it's manslaughter, and you've seen a number of cases around the country going into that. So then it becomes criminal, and then someone has a charge to answer to on manslaughter. That, but still the civil part. So it can be both.
Okay.
Yeah.
So then, what is the pushback against the fine and the jail?
I don't think the pushback is the fine. The pushback is, even within our judicial system, we use proportionality, we use reasonability in any punitive measures, right? When a mistake, let me not say a malpractice or a negligent case has happened. We've seen, I don't know if you guys know about the case around one of our biggest private hospital, where a woman had had a form of contraception, and then she got pregnant, and she sued the facility, and it was a huge amount of money, and then it was reduced, So it depends on the circumstances and the facts of the case, and so the court would be able to. So when you blankly say 10 years and 50 million
for all cases
of negligence, without being reasonable around what is the quantum, what is the harm that was caused, right? You cannot quantify a loss of a finger to a whole loss of an arm, a loss of life to a loss of an eye, and so you have to be reasonable when you're making such proclamations, and so that's very problematic.
It's a trend we're seeing, right? Isn't that the conversation we had around the weaponization of some of the laws that we're seeing? And maybe we can transition to that, Dr. Ari, because what you've painted there is a picture of this blanket, just kind of dealing with matters. And we're seeing that as well in many ways. We even had Senior Counsel Martha Kora speak to it. Your thoughts on how, I'm just trying to chart a path for Kenya years from now. Like I said, let's go back to the protest. You've been very vocal. You've been an ally and champion in trying to seek justice. When you see everything that's happening, whether it's with the courts, whether it's with the protesters, how then do we begin to chart a path forward where 10 years from now we can say, because we were able to unravel this, it's given us the access to justice that we have now a decade later?
The beauty about the Constitution of Kenya of 2010 is the separation of powers to the executive, to the judiciary, and to the legislature. And this really moved us from, we hear stories and we read books before pre-2010 Constitution, where power was heavily centralized within the executive. And so what we're witnessing right now is, when we talk about independence of bodies and the constitutionalism of the country in terms of the practice of the judiciary, and we're seeing in many instances where the judiciary has really come out and said, you cannot weaponize the judiciary for all intent and purpose. Bring in a charge sheet that is defective on a charge of terrorism, when really it's not terrorism, or arson when it's not arson, or whatever charge that we've been seeing which is defective. But who is doing this? Unfortunately, it's the executive. It's the executive that's giving orders. It's executive that is using police. That's why we're witnessing police brutality. And I talked about, people just think it ends in the bullets. No, go to Kenyatta National Hospital. What Dwali was speaking about, you cannot share beds. You'll find those young people who are short. So it depends. If you're recovering earlier, we transition you to the floor. Yes, if you're more complete, that's actually what we do. There's a transition from the bed to the floor, depending on how quick you're healing, right? You'll find them there. So it's a cost to families, it's a cost to healthcare. And so when we are weaponizing the police and giving them blank directives, shoot, but don't shoot to kill, shoot to maim, shoot the leg. So in essence, in the next 10 years, as we've witnessed in the rest of the world, rather in the next 3 years, this administration, it has 2 more years, we will manufacture disability. We continue to manufacture disability. And we are manufacturing disability in the youngest population. You should hear how we pride ourselves around demographic dividend. A country that has more than 70% of our population less than 35 years. But we are manufacturing what? Disability. That's the thing. But we are also manufacturing post-traumatic stress disorder in the long run.
Yeah.
We are such an angry country.
Yeah.
Small thing, yani inatukasirisha, and people think, oh, kwani ni hasira gani hizi tuko nazo? No, it is we have watched a 12-year-old child, and they call it a stray bullet. There is never a stray bullet. That bullet was shot with an intent to kill or to harm, to cause permanent damage. Bridget in the house, and the loss of life. We have seen a young girl protesting, peaceful protest, Inca severe head injury, and you're told they banged their head on their wall. And then postmortems are done, you're told, my goodness, intracranial bleeds. This is trauma, blunt trauma properly, that hit somebody for them to actually be able to lose their life in that essence. If this executive doesn't do right by people, and I hope William Ruto, his handlers, are listening to me, and they're not asking for so much. The Kenyans are not asking for so much. They're asking for respect to the rule of law. They're asking for accountability, because the rule of law then branches in and says, can we hold people accountable? Can each and every state officer, as is provided by Chapter 6 on integrity, be held accountable for their commission and omissions? Can we be able to recoup all the resources that we have lost in this country? Kenya is one of the countries on the radar around illicit flow of finances. Our monies are in Dubai, our monies are at the Cayman Islands. Can we get that money back so that we stop talking about underfunding in healthcare? And by the way, healthcare is not just about the healthcare facilities. We also need to discuss about nutrition. Initially, you had a guest who spoke about sanitation and water. We need to talk about food security. An apple a day keeps me away. I mean, this is a very hungry country also. And so we need to be able to sort all those social determinants of health, including housing, for us to actually set this country straight. But the president must also realize that this country is not short of leaders. That we don't have certain leaders who are aham, who give directives for people to be killed, who give directives for people to be shot. We don't necessarily need to have leaders who have watched us pay ghost schools in billions, yet our secondary schools, boarding schools, and primary schools are at the verge of collapse. And it is fine. And we can't watch when our military right now are being starved because of what? We can't. Our first defense is our army. And yet right now, we know it's out there. Their lunch has been cut. Part of their meals have been cut. Why are we starving our military? And yet if there's a threat to this country, there will be a first line of defense. Like if this man, His Excellency William Samoei Ruto, could sit, I could even provide footnotes. Kenyans would provide footnotes. The young people have provided footnotes. And just listen. And not listen to respond. And just listen to say, I have 2.5 years. What can I do?
Yeah, how can we turn this around?
How can you turn this around?
Jenga Njoku says in the 14th Parliament, people like Dr. Stellah should be dragged to Parliament through appointment. Yani, you'll be forced. Nenda uketi.
Serve the country.
Serve the country. You'll be told here is a chair. He's a chair in the health, given committee chair in health, and make bills that will streamline health sector. Hannah Munyao, Dr. Stellah is sharing deep facts that have made our healthcare not work. I'd like to hear what she's doing in her own right to try and correct the system. And then we have, I just thought I'd read that feedback because I know we'll end soon.
Kikombe says, accountability before conclave. Donge.
Let's go accountability first. That question around what you're doing in your own right. Again, we've been asking some of our guests about Beijing at 30, turning 30 this year. And I know you've spoken about the intersection of health and economic power. Is that part of what you think needs to happen now? Do you think that's a way to pay homage to the legacy of Beijing at 30, and maybe speak to what that means, intersection of health and economic power, and why that's important for women 30 years on?
My work right now, I lead an infrastructure called the Center for Health Systems and Gender Justice that is using economic power as a tool to address health equity and inequalities from a gendered lens. And basically what we're saying is, when we improve the economic independence, we increase access to capital, we improve the skills gap, we increase access to skills like entrepreneurship, particularly around not small and medium most of our women, most of our vulnerable population are neither small or medium enterprises. Literally, there are women whose capital is $100, whose capital is 5,000 shillings and 10,000 shillings. When we shift that and start supporting these women, what we are doing is that we're building agency, we're building autonomy, and in the event that we do that successfully, these are women whose purchasing power improves. These are women who are able to, for instance, you know, gender-based violence, a very huge component around poor health outcome, from physical to mental to social. We are able to have those women and girls escape those violent environments. We're able to see better decisions that are being made around nutrition in homes. So we'll not have malnutrition, because what? We've shifted power around reducing the income inequality, addressing injustices around economic injustices, to be able to ensure those who are vulnerable, those who are marginalized, including women, are able to access capital. The other thing that I'm doing, and I'm actually pushing the private sector, is to be able to start thinking about when we had one of the biggest, and I'm not going to mention because I'm not here to speak about them, one of the biggest fintech solutions, it was supposed to improve access to financing to people at the level of village and the low informal settlement areas. Right now, to send 100 shillings, you need to pay about 39 shillings. And so if you take 39 from the 100 that they are sending, the other person who is withdrawing has not even gotten their total amount of money. It's very costly. They need to go back on the drawing board, because what they've done is that they've continuously increased that gap, the inequality, the gap around income for these women. Now, the other thing also, it's not just them. It's also a question, and this is a question to His Excellency, is around taxes. You cannot tax the untaxable. You have taken and you have taken. There has to be another innovative way of doing this. I gave a preposition around syntax. We have products in this country that are making our children sick and giving them obesity. Tax sugars. Tax processed foods. Tax them, right? Tax that to be able to mobilize resources to actually, I spoke to one of the members of parliament. I said, I want to bring a bill on syntax, and he said, bring it. I know they'll shut it down very quickly because of other interests, but that is exactly what we are thinking about, that you have to put money in the hands of women and vulnerable populations to improve their social and economic status.
Wow. Thank you so much, Doc. We're running out of time. I wanted to give you the 138 billion that's been given to health in this financial budget and see how you would spend it, but we'll have to do a part two.
Yes, that's a good one.
I want Stellah's budget.
Stella's budget.
Stella's breakdown.
Maybe that's the next article I need to write on the nation.
Yes.
What I would do with 138 billion.
That's a good one.
I hope the first thing you'd say is devolve it to counties.
That,
if you don't say that,
that is literally that should begin and end.
And
our
there.
Facilities and the national government has no business in facility services.
As they do their handshake, Helen Aura today is hosting your world. Hey, Helen, my body versus me, lupus, battling autoimmunity and beyond. Today really has been a health day. You know, having Dr. Stellah, having Wali, and now Helen Aura is going to be hosting that. And then Vibe Shift, Mariam?
Right, on Vibe Shift, Brian Aseli and Claudia Naisabwa are there, 10/10 music. It's not yet Thursday, so it's not yet throwbacks, but tune in 96.3 Nation FM, and of course across the country on ntvkenya.co.ke/Nation FM. Aseli and Claudia, my vibe. And again, I'm just requesting all my enemies are suffering to be the first song. Please. Hi. Tupatane kesho asubuhi.
Yeah, thank you.
Ianze na maombi ya nani ya DJ Shiti.
Yes.
Ianze hapo from the very top.
So I don't know what he's saying about Baphomet. I'm just like, okay, DJ Shiti.
Yes,
I hear you.
What you said.
Yes, you.
Thank you, Dr. Thank you as well to all our guests.
Are we off?
Yeah.
No, we're just going off now.
Yeah. Dr. Stellah Bosire is a medical doctor and a lawyer. As a doctor, she knows how to inject. That's what she's just been doing here. As a lawyer, she knows how to do the mbogi thing. That's what she's also been doing here for the last hour. Thank you very much for tuning in. We are glad. So those two places, go to NTV or Nation FM. We'll be back tomorrow morning, 6 a.m. to 10 a.m. Or maybe Mr. Kuwa kesho, lakini Friday. Mungu akipenda, tutakuwa hapa. Have a lovely day.